Okay. Then we have our third prize talk is supply chain alternatives for last mile, called Scale, and it will be presented by Daniel, but they have submitted a recording. So I'm going to shortly play that recording just now. So just give me 1 second. I'll pull that up and.
Hello and welcome. Thank you for your interest in our presentation, in which we will share our experience in implementing a 3-year Bill and Melinda Gates Foundation funded project called Supply Chain Alternatives for the Last Mile Equity Scale. I am Danielson Kennedy, a Senior Monitoring and Learning Evaluation Advisor with InSupply Health, and with me is
Joyce Owola, a Supply Chain Analyst.
And George Okello, a Senior Supply Chain Analyst.
Also working with me at InSupply Health, whom you'll hear from as they present other sections. As a note, we'll be using the acronyms SCALE for Supply Chain Alternatives for the Last Mile Equity, DE for Developmental Evaluation, CHV for Community Health Volunteer, CHA for Community Health Assistant, and ASAL for the arid and semi-arid lands, quite a bit throughout this presentation. We have divided our presentation in 3 sections. We shall let you know about InSupply as an organization first, then we shall present the overview of SCALE project, highlighting the key approaches used during the implementation, how we measure impact, the changes we made during implementation, challenges we encountered as we implemented, our key achievements, as well as the long-term sustainability of the project.
InSupply Health is an advisory firm affiliated to John Snow Incorporated Research and Training Institute that provides a customized guidance on supply chain management and design to clients. We seek to transform lives by co-creating innovative and sustainable solutions for healthy communities. We are based in East Africa with localized leadership with a global perspective, having offices in Tanzania and Kenya. We envision collaboratively designing solutions to health challenges with communities. I welcome my colleague Joyce to take us through to the next part.
Thank you, George. I shall take you through the overview of the SCALE project. As highlighted by my colleague George in the introductory slide, through the support of Bill and Melinda Gates Foundation, we are implementing a 3-year project in 4 ASAL counties, that is Samburu, Turkana, Wajir, and Mandera. SCALE aims to address inequities in access to health commodities by developing sustainable, scalable, community-based distribution models that reach the underserved, remote communities and improve their supply chains. We partnered with the Ministry of Health, both national and county governments from the 4 counties, AMREF, Health Africa's Afya Timiza project in Turkana and Samburu, and Save the Children International's Nomadic Health project in Mandera and Wajir to increase demand, improve service delivery, as well as strengthen supply chains for the provision of community-based services. It is important to highlight that the ASAL populations are generally marginalized, remote, hard to reach, and often migratory due to the nomadic lifestyle. The community health strategy as defined by the National Ministry of Health also lacks specific focus on the challenges and realities of the ASAL counties. The neighboring regions are Sudan, Ethiopia, and Somalia, which also have political instability. Thus, the communities migrating to these areas can't access the healthcare needs they require at an affordable cost. Because of the unreliable or absence of supply chain procedures and resupply processes of the commodities to the CHVs, this is a challenge. Nomadic nature of the communities also poses a challenge in resupplying CHVs, mostly causing stockouts during the migrating seasons. In addition, the nomadic communities have poor health-seeking behavior, low literacy levels, and the vast health facilities, which are far apart because of the geography of the area. And the human resources to serve these communities is also inadequate. We adopted the human-centered design approach to understand the contextual issues and provide localized solutions to address the supply chain challenges in the SAL communities. HCD is an innovative methodology that puts the creation of solutions for users' challenges back into the user's hands. It allows stakeholders to participate in a constructive, creative process where different perspectives are encouraged and navigated through structured facilitation. Through the HCD approach, we involve the voice of the user from the project inception to understanding their problems and their needs, to prototyping solutions early and testing them with the users, and finally, forming solutions that are both wanted and needed. Through a 6 months process, we conducted research and generated insights and personas that we used for ideation and prototyping with 62 stakeholders from all the levels of the system, including community and religious leaders in 2 ASAL counties. This included county and sub-county community strategy focal persons and pharmacists, community health assistants, CHVs, health facility in charges and community members and their leaders. I welcome my colleague George to continue taking us through the details of the SCALE approaches.
Thank you. SCALE deployed 2 interventions, the impact teams and CSTOC approaches. Impact teams, where impact is an acronym for information mobilized for performance analysis and continuous transformation, is a structured supply chain problem solving and action planning approach that serves 3 purposes. First, supports strengthening data use and management processes and practices. The IT approaches is made up of people across functions and disciplines who meet routinely and are trained to develop, interpret, and set targets for key supply chain indicators and use action-oriented dashboards and are encouraged to follow a structured problem-solving process and empowered to use their data for operational and strategic decisions with ultimate goals of improving the performance of supply chain. We deployed impact IT approach at county, sub-county, and community level with CHVs and CHARs. Secondly, IT approach supports enhancing individual and team continuous performance improvement, and finally improving supply chain outputs and outcomes. Impact teams are anchored on 4 elements that have been key to us. That is, it's important to have people who are motivated and with skills and capacity to do their work. Thus, in addition to supply chain skills, the ITs need to have people with data analytics and visualization. There is need to have processes that ensure that mechanisms to facilitate data-informed decision-making, functional logistical data systems and decision support tools such as dashboards are available and adopts technology. In addition, the availability and commitment of both formal and informal leaders to facilitate supply chain decision-making. These 4 must be applied together, with each playing unique roles for greater supply chain performance. We deployed materials and built the capacity of healthcare workers to implement supply chain models while monitoring, learning, and adapting them using adaptive learning and developmental evaluation. We promoted competency building and learning through learning packages, self-directed online-based modular course designed to meet the needs of teams focused on competency building for the improvement of health supply chains. They are hosted on the IT portal designed for the ITs and can be accessed at any time and by IT members. CSTOC approach is a supply chain strengthening approach which enables CHVs manage commodities. CSTOC created a community health supply chain that responds to strengths and weaknesses, ensuring the availability of critical commodities in ICCM and CMAM programs, and consequently increasing access to essential health services and life-saving interventions at the community through community health volunteers. CSTOC uses 3 components. 1, a mobile technology, which provides logistics data. 2, a user-friendly dashboard, which enhances end-to-end data visibility with standardized resupply process. And 3, impact teams to strengthen data use, communication, and coordination in local problem solving of supply chain. We integrated CSTOC in Kenya Health Information System, KHIS, the platform that is integrated with indicator tracking tool, an automated user-friendly dashboard that housed all supply chain indicators that was used by both the MOH staff, partners, and project staff to track supply chain performance at community and facility levels. This enabled the teams to identify and make decisions on both the facility and community level supply chain data and address stock imbalances. The HCD approach supported contextualizing CSTOC to different settings. We had 3 solutions. First, we had the Android solution that incorporated voice on the commodities CHVs reported to provide data visibility. Second option was to support the CHVs with feature phones, and the last option was a solution for CHVs who were illiterate. They take pictures of the manual report and upload it. The CHAR portal design enables the CHARs to support CHVs data entry with 1, validating points where they review the quality of reports CHVs submit. 2, user management, enabling the CHAR to add and edit CHV details. 3, user-friendly dashboards to track CHV's performance, check stock status, and resupply calculations for CHVs per month. 4, delegation to support CHVs who cannot report. And lastly, CHAR reporting on the receipts.
Thank you, George. The DE approach was embedded in Scale to inform collaborative learning and continuous improvement. DE is an evaluation approach particularly useful in complex environments and supports adaptive learning and innovation by providing structure, rigor, and data to the process. The approach used real-time data and collaboration to inform the intervention itself. Our DE methodology was 2-pronged. First, the evaluation team was embedded within the project implementation team to participate in uncovering patterns, highlighting learnings, documenting implementation dynamics to identify when and where adaptations were needed. Second, our evaluation team collected primary data every 3 to 6 months. Each wave of primary data collection prioritized 3 to 4 learning questions that were developed jointly and were of high interest to the 3 projects. Data collection was highly qualitative, collecting information from women, community members, and health system personnel. The data was analyzed jointly through a facilitated process, looking at true and initial themes to generate insights in light of what had been done and how the projects needed to adapt and adjust to fit the unique settings. Through DE, the project generated evidence and learnings for sustainable and comprehensive community health models for increasing contraceptive use in remote and hard-to-reach communities that are applicable to regional stakeholders dealing with similar populations in other countries in the sub-region, the Horn of Africa, and the Sahel. We identified and documented the process of implementing and adapting supply chain and service delivery models in ASAL counties. To measure the outcomes and impact of the project, we identified both supply chain and non-supply chain indicators. The project identified ways to measure increased availability of expanded mix of contraceptives and other health system commodities through the community health supply chains in remote and hard to reach communities. In particular, we tracked the percentage of stocked out of stressor commodities over time, average stock out days by the CHVs, and the percentage of health facilities stocked out of tracer commodities over time. These were discussed during the monthly impact team meetings. Corrective measures were taken to ensure continuous availability of commodities. The supply quantities of commodities to the CHVs was informed by CStock. We thus measured the percentage of CHVs ordered, supplied in full, that is at least 80% every month through the order fill rates. The use of CStock for reporting of commodities was also being tracked. We tracked percentage of CHVs reporting on CStock every month and further looked at those reporting on time. Stock status by tracer product by level of system were also critical components that were tracked. Specifically, we tracked the month of stock, that is MOS, that the CHVs had. In addition, we tracked the number of trainers we completed, including the Ministry of Health, counting and implementing partners to manage sustainable reporting, supply, and commodity management system. We also documented barriers to CStock to supply chains in ASAL counties that were identified using human-centered design and DE throughout the project. Reports show improved reporting rates as well as availability of stock as shown by the web dashboards that we supported develop. Commodities were available in majority of products. However, there were still stockouts which were experienced. We evolved our implementation. We moved, for example, from web-based Excel indicator tracking tool to a web-based dashboard that automatically pulled data from KHIS, that is DHIS2. In the course of this, upon request by the counties, we expanded the ITT to include not just the immunization and family planning commodities, but added malaria, nutrition, and CStock commodities. We integrated CStock with KHIS, which is the Kenya National Health Information System. We made changes to the initial version of CStock to respond to the needs of the ASAL communities. As we've mentioned, we ensured that we had a portal that decentralized management of the users. We added simple dashboard used for management of performance on the phones. We introduced, as mentioned by George, voice along the pictorial icons so that we could support the illiterate, low literate populations. We introduced the USSD to support CHVs who had feature phones. And we also supplemented power issues by supporting the CHARs with solar chargers. Lastly, we introduced paper to digital option for taking pictures, which could thereafter be uploaded for reports. In addition, in particularly Samburu County, we initiated, which initially did not provide CHVs with commodities, they adapted CStock and started providing CHV with commodities. The nomadic health project, which is supported by Save the Children, provided the nomadic CUs and formed the nomadic CUs and provided them with commodities. The results of DE were used by the National Ministry of Health to inform the review of the community health strategy. And as also mentioned, the introduction of the learning packages based on adaptive learning and role profiles was a major adaptation that and change that we made in the course of our implementation to respond to the needs of the teams. We had some challenges, and one of them is the inconsistency in scheduling and facilitating regular impact team meetings. The county governments and sub-county health management teams sometimes were not available for the meetings. We were able to see disparities between what is laid out in the community strategy by the national team and the actual practice. For example, factoring the needs of the low literacy in these particular regions. Data analysis and visualization capability was limited and mostly anchored around the health records and information officers. However, we were able to come up with the ITT, which was able to support the teams. We had poor connectivity. Of course, this affected the adoption of mHealth technology. However, we also ensured that we had an opportunity to have the offline ability of the solution. There were also limited knowledge on supply chain, among other challenges. Now, some of the things that we were able to identify as the key achievement were through the outcome harvesting approach. And I would highlight the key things such as we identified increased visibility for supply chain data up to the community level. We initially did not have the community level data, which is directly attributable to the adoption of CSTOC. We had improved data quality for supply chain. The impacting monthly meetings which were held, they were reviewing key indicators for supply chain. We also saw timely solving of supply chain challenges which were faced by different teams. There was improved motivation, of course, by the healthcare workers, and we are proud to say that CSTOC was integrated with the national information system, that is the GHSCS, and also recommended as a solution, as a module for supply chain in the electronic community health information system, again by the Ministry of Health. Now, the ability of CSTOC to track commodities, these increased transparency and accountability and resulted in health system actors in the 4 ASAL counties being more comfortable allowing CHVs to manage commodities. To ensure that we had long-term sustainability of the project, from the word go, we integrated sustainability at the project design through the support of the HCD, which supported co-creation with the counties and enhanced inclusivity and sustainability in programming. We recognize the power of partnerships. That's why we partnered with AMREF and through their project Afya Timiza and the Nomadic Health Project of Save the Children, together with the Ministry of Health. The adoption of DE enabled the project to monitor institutionalization and scale up and sustainability during the implementation. Now, we ensured that we did not train ourselves. We trained TOTs who are able to go ahead and train. So we believe even when the project is coming to an end, the Ministry of Health has a pool of trainers who will continue to do the work. We developed numerous resources like the indicator tracking tool, the platform CSTOC, the virtual learning packages, and these remain available to the counties. And we've also transitioned some of them to the partners. The project developed standard operating procedures for use by the CHARs and by the CHVs, and these still remain resources that are available even as they're onboarding new members. Now, we also ensured that we developed a joint sustainability plan that involved the implementing partners and the county governments. Lastly, we developed a mentorship toolkit that forms a resource for onboarding partners ready to continue implementing scale approaches even as we're coming to an end. Some of the lessons that we learned is that it is critical to ensure that CHVs can effectively engage with technology. Like if you want to implement technology, it is good to train, because even in the places where there's low literacy, there are skills that they will be able to acquire with time. Now, it's important that there is need to establish storage structures for commodities in the link facilities where CHVs can safely store and access the commodities. Now, one of these lessons is that the motivation remains a major factor for ensuring success. This requires multifaceted approach. We now welcome any questions from the team. Thank you.
Thank you. I'll stop sharing and go to invite the judges to ask the questions first, before we open it up to others for asking questions. So on the presenting team, who's going to respond? Danielson, are you going to respond to questions? Do you have other team members online?
Yes, we are together with George. We are seated together.
Okay, wonderful. Are you able to turn on your video?
Thank you. We're just trying to save the bandwidth, but we turn it on.
Fine. That's okay. Don't worry. If it's a big problem, if the bandwidth becomes a problem.
We are both of us here.
Yes. Okay. So judges, questions. I see David and Anato are unmuted, so perhaps you're maybe ready to go.
Thank you very much. Yeah, so look, I think there is something there. My only concern was how you presented it. Because for instance, at the end, you talk about storage. I wanted to see some pictures because I don't know Kenya. I don't know what you're talking about, or even the hard to reach communities. So I think from a presentation point of view, it would have been nice to be more visual, more pictorial, probably. And then the question I have is, in these communities, we always have traditional healers, however you might want to call them. How did you bring them in, if at all? Because when these people migrate, they would also then migrate with those traditional structures. And I didn't really see how you try to bring them into this.
Okay, just before you respond, just hold off on that. Maybe Anato, you have a question? Let's take two.
Yes, I have. Okay,
Yeah.
Thank you very much. And thank you, Mr. Speaker, for that presentation. However, I do have a few questions or comments, as you may call it. First of all, overall, because you presented a lot of activities, it's a little bit difficult to be able to link any specific intervention with a specific outcome. That was difficult to link. Even in the submitted abstract, I also find it difficult to link any particular intervention that led to a particular outcome. Then having said that, I want to believe there were some desired or expected outcomes from this project. Perhaps you may want to tell us what were those desired or expected outcomes from this project, and if those outcomes were met. Were they met, and to what extent they were met, whether fully or partially? Maybe with that, we might be able to disaggregate the whole presentation and being able to link specific intervention to specific outcome. Then I also had a lot of sustainability. You mentioned sustainability throughout in your presentation, but I'm unable to lay hold to a particular sustainability strategy that was used, because of course you had a bouquet of activities, on this project. Then, and if you say that yes, sustainability was planned into the work, and I want to believe that the project has ended, right? So can we now say that the community or the health system, they are not able to routinely carry out these activities, at the close out of your project? I think these are some of the concerns that I want you to clarify. Thank you.
Wonderful. Thank you, Professor Nato. So maybe Danielson, you could take it up. I think I see three issues between David and Professor David and Professor Nato. One is around the traditional medicine because of the nature of the community you're talking about. Second is about the metrics, lots of things going on. Is there a way to identify specific outcomes? And then the sustainability question. Over to you.
Thank you so much.
Yes.
Thank you for the great question that we got. I'll take the first attempt and George will answer additional questions. So first, the traditional healers. At the beginning, maybe this past, we said that we employed the human-centered design and we brought in different stakeholders. So when we went to the ground, we were very intentional. We brought in the patriarchs, we brought in the community members, we intentionally identified the traditional healers, and we went to the health system actors, like at the county, that is the county is the first subnational level, sub-county, but went up to the ground. So the ASAL counties, you'll find that it's true. So by the time we were designing scale project. Some of the issues around family planning were clear issues where men were taking matters. There were issues around health-seeking behaviors. So it defined how we actually intervened. So we were intervening both at the health system, that is for the health system, but also going up to the community level. So that's the first part. The comment around the storage, maybe sorry about that, we didn't include more pictures about the storage, but I want to give you a picture that some of the distance between one facility to another is actually between 20 to 40 kilometers. So the primary people, we call them community health volunteers, but the traditional word which is known is the community health workers. So in the context of Kenya, they are called volunteers because they are not being paid. So you find that they may not have adequate bags, what to use to carry the commodities that they do the distribution. The question on linking outcomes and intervention, and thank you for that. So as we began, we said that we were trying to find models that we could use to strengthen supply chain, so that we're able to say that for community-based distributions, for us to ensure that commodities reach the last mile, this and that is what is required. So we were intervening at the national level, at the county level, at the community level. So some of the barriers, when we were beginning, there was nothing like community-based distribution models which were existing in terms of like supply chain. We didn't have ways of tracking or measuring community data. There are data up to facility level, but the data on supply chains were not there. One of the things that I've talked about is the direct integration of CSTOC, which is the community health supply chain tool, to the national Kenya Health Information System, the DHIS of the country. The country is reporting on DHIS. So we worked with the national government so that we integrated. So as the CHVs are reporting at the community level, that data is available for all the users as a whole. So they're able to access the data and see what is the contribution, what commodities are going up to the community level. Another thing that we talked about are the interventions that we put in place, the quality improvement approach for supply chain at the county level and at the sub-county level, so that we brought in multidisciplinary teams so that they're able to routinely look at supply chain data. On a monthly basis, they look at data so that they have a structured approach, they do root cause analysis, they do their action planning. And one of the things that we showed was how you can see over time, we have like the stocks, we now have adequate stocks in some of the places, despite the fact that there are some challenges that are beyond the impact teams, like the health management teams. Because when the government has not purchased commodities, there is just so little that they can do. For the sustainability, I think there are so much that we talked about. Maybe I can highlight them again. The first thing is linking. When you have a digital solution, when you've already integrated it with the national government, it means that this is something that is being used. It's being used even when the project is coming to an end, and we've seen part of this approach, we used it in another county where we stopped direct support. This one, we are going to stop any support this month. And we are seeing that they are able to report even beyond data is being used. We have put in place what we call the learning packages. These are learning, online, self-paced learning tools that the healthcare workers are able to log in. We've given them that. We've given them simple ways of looking at data through the dashboards. So we have automated a way in which we've used Power BI to bring out the data from DHIS, that is the Kenya Health Information System, to present the logistics data. I can do a live demo so that you're able to see. And we've automated it such that anyone in the counties are able to use this. They don't need anyone to download data. They don't need someone to be pulling data every month, because this is an automated process. And as long as DHIS is live, they have the data. I've talked about availability of TOTs so that the counties are training themselves. So when there are staff attrition, they're able to train themselves. I've talked about partnering with other partners and the county governments. Like when we are living right now, we have transitioned some of the activities to Save the Children to continue where the government is asking them to take in, to scale up like CSTOC to other sub-counties where we are not working. But at the same time, the county governments have put in resources so that we don't need to be buying for them bundles. I think one thing I'd want to talk about on the digital solution, we are not providing any funds. We just provided platforms and they're using funds that they have. It means that when we leave the digital solution that we have brought in for the community health workers, they are still able to use them because they were not relying on us to provide them with funds. So that's why we gave solution which can talk about, you have, if you have a feature phone, if you have a smartphone, and even when you don't have a phone, then there is the solution can work for you. So I think with those many comments, I don't know if George, you have an additional thing. Thank
Great.
you.
Let me interrupt us, Danielson. Thank you. But, you know, maybe I want to give the opportunity. We have to wrap up in about less than 5 minutes. I want to give the opportunity to the other two judges, Molly and Anne, to ask questions, and maybe you or George can respond accordingly. Molly?
Thanks. Yeah, I'll make a quick question, Anne, so you have time for your question too. So I guess my question is, I think one of the fun things about human-centered design is that you get a lot of different ideas. And so I'm curious, as you were implementing, if there were things that you were not able to build into the design that maybe as you think about the next phase, you would do. And so I'm curious if there are any of those kind of requirements or you know, wish list items that are on the list. And then I'm curious, are there plans for a next phase, or has this just now been handed off? Thanks.
Maybe Anne, you can also ask your question and then have them respond.
Yeah, I'll be succinct. I wrote a few questions, but I'll choose one, which is around, can you, in one sentence, provide a view of what the baseline was and what you were able to achieve in terms of quantitative supply chain performance?
And so as you respond, I would like to add, you know, don't want to kind of, you know, we see a lot of such initiatives, which is great. I mean, you show performance improvement, but I think it's useful to kind of think about the cost investment to get that improvement. Because that also leads to sustainability, because one is sustainability in use, but technology is not static. Things will get obsolete and things like that. So at some point that needs to be upgraded, etc. So, you know, but give preference to Molly and Alan's question. If you have time, you can address the cost issue.
So thank you so much. So one of the things that we maybe I'll start from the last part. I also mentioned about the electronic community health information system. So we are working with the national government so that, because we know that the government has got some initiatives to pick up some of the digital solutions. So the government realized that they don't have a community, we are trying to bring up a community health information system, but there is no supply chain module. So CSTOC was picked as part of what will be the supply chain module, which can be scaled up to other places. Currently, we are working in, I've presented for 4 ASAL counties, but we've also scaled it up to an additional county. So in terms of results, if I look at number one, I'd say we did not have data for community supply chains. It was 0. Right now we have data. And as by the time that we were sharing this data, we had up to 71% reporting rate among the community healthcare workers. Then we also had, even when we look at stockouts, so you'll find that where we are implementing the impact teams, the stockout rates have considerably reduced. I think I didn't issue out these, but if you look at some facilities that are overstocked or adequately stocked, you find that there are issues that we can't intervene. Like I've said that part of our intervention was not providing commodities. So if I come back to my wish list, if given an opportunity, is to try and work with the government to see what is it that we can do to ensure that commodities are available. I know there was a lot of disruption with COVID. HCD gave out some strong things on the role of men in provision of family planning issues. We were not able to intervene in that particular area. So that is something that is still remaining. The motivation of community health volunteers, because they are volunteering, they are not being even given some stipend. But we worked with the county governments to try and see, right now we know there are draft bills, so that the county governments are trying to see if they can put in some resources. But even in the country where we have stipends, this is not regular. So I think that is, again, another wish list. The whole area around motivation and, of course, the human resources for health, which is really strained. So thank you. I'll leave it at that particular point.
Okay, I think that's all the time we have. Thank you so much, Danielson and George, and thank you, judges. So this ends this presentation, and that's the end of the prize competition. So we now, I invite there is a regular panel presentation. It's not a talk, but it's a panel called Digital Transformation of Regulatory Systems, the Missing Link in Transforming Health Supply Chains. We have a team here. I don't know if all of them are here, Al, Hiran, Teddy, and Rami. But over to you, whoever is managing that panel. And judges, you're welcome to, be here or log out, but the panel will continue until the end of this session. Yeah. So Al, over to you. Al, over to you. You're unmuted.
Oh, sorry, I was on mute. I apologize for that.
Yeah.
Thank you, Dr. Ravi. And I believe someone's going to.
So you.
For us? Yeah.
You have your slides with you to share? What is that?
Sure. Somebody had told us, but I can share. It's fine.
So you have permission to share. I think it may be the best because you're managing a panel.
Okay. All right. Just one moment, please.
Yeah, we can see it.
Great. Okay, welcome everybody, and thank you for having us. So with me, I have Dr. Rami from USAID Washington and Teddy from USAID Ethiopia. And my name is Al Shafrao. I work for the USAID Digital Health Project in Ethiopia as a Deputy Chief of Party and Technical Director. So as Dr. Ravi opened the session, we're going to be focused on the regulatory information systems, and the focus is highlighting that it was a missing link in being able to provide the digital transformation of the health supply chain in general. So I will be doing the introduction, and Dr. Rami will do more of the global impact, and Teddy will be covering the work that was done in Ethiopia, as well as on behalf of our colleague, Ms. Hiran Garba, who is the Director General of the Ethiopian Food and Drug Administration. Okay, so as discussed in the plenary and other sessions, there's full understanding and agreement that data and digital transformation is at the core of transforming supply chain systems and being able to provide clients. So we've been working in that space, most of us, for the last decade or so, and the focus has been mostly on the supply end of this work. However, we believe, and we're making the case, that the regulatory frame system is also a backbone of the health supply chain system. And for that to happen, that area of work has to be digitized and digitally transformed. And for cases I would be making in the next few slides is this section, this part of the work has been left out, or in some cases lagging behind. And without getting the upstream, as my colleagues will be describing, it will be very difficult to be able to provide the whole system of the supply chain system working from the point of procurement, contract management, and be able to provide the transparency and integrity of the health supply chain system that eventually we all aim to provide better care and access to the patient. So in a quick summary, the argument here is that the data digitization is quite key, and the component that's been missing has been, or lagging in this case, is the regulatory information system. So my colleague Teddy will go in detail about this, and so as you can see, right here, we've been able to highlight sections of the regulatory environment system, as well as the supply chain management system. So on the left, there are a number of components, and then on the right, the similar components on the regulatory side, on the supply chain side. And so I won't go in detail about it, but I invite you to look at the screen for a few seconds as I hand over to my colleague, Dr. Rami from USC Washington. Over.
Thank you, El. And if we can go to the next slide. Yeah. So I would like to just discuss and provide more of an overview about what's the trend happening in the digitization, digital transformation of supply chain, and what we are seeing more at the global level. So there is an overall trend, both I think at the country level and the global level, from moving from reporting system to more a transaction system. Also, the supply chain information system is becoming more and more complex with a wide expanded functionality that's need to be automated. So as we can see from the diagram here, we are not just talking about like order management like in the past, but there is the forecasting and planning, there is the order management. Sorry, Al, can we have the previous slide? The previous one, Al. Yes. We have also the procurement, we have the transportation, we have the warehousing, we have contract management. So there is a lot of functionality in the supply chain that is currently being subject to automation. In many cases, it is not just one system that automating this functionality. One other major transition that is happening, it is now not anymore when we talk about supply chain information system and digital transformation that we are talking about one organization. In order to be able to have the full visibility of the supply chain, there is going to be multiple systems handled with multiple organizations, and there will be need to have this interaction and exchange of data among the different organizations. And this is where the regulatory body also will be coming in the picture, because again, it's not just about whoever is doing procurement or the central medical store, but it's becoming more supply chain and regulatory and also interaction with health information system. And of course, with all of this level of interaction, we see now that data quality and there should be major emphasis on data governance and how we can ensure the integrity and the quality of data. And next slide, please, Al. Yeah, so in general, we can see the digital transformation is really becoming very critical. It's increasing the efficiency and transparency. There is a lot of inspiration now that everyone would like to capture data from the manufacturer point, from the manufacturer till the end beneficiary. There is more and more emphasis now in applying and adoption of standard. And of course, we can see specifically now what becoming more default at the global level is the electronic exchange of the data and the what we call also the ADI. And next slide, Al, please. So, in order, again, the applying of the technology, it's becoming very critical to achieve the vision for the end-to-end data visibility, for traceability, to reduce the risk of fraud, to increase the compliance, and for counterfeiting. One thing that I strongly believe in with the level of the adoption of the new technology in the supply chain, I strongly believe that in few years, there is a risk that we're going to see what we can call it a supply chain digital divide. This is where there will be a huge difference in the performance and in the operation of organization that were able to adapt digital transformation, adapt more technology in their operation, and the organization that has been lacking behind. To the extent, like if everyone remember, maybe 10, 15 years ago, when with the start of 20 years, with the start of the internet, there have been creation of a digital divide between countries and people who have easy access to the internet and not. I'm expecting next few years, we are going to see this major digital divide in supply chain and the level of how the organization are able to adapt and implement digital technology. Next slide, Al. So one of the key points is where to start and we should have the foundation for digital transformation, because again, it's not just about supply chain, it's not just about one organization, it's include also the regulatory body, it's include the linkage to the health information system. And one of the major foundation for the digital transformation should become through the adoption of standard. And we all know that there have been huge interest in the last several years, both at the global level and the country level, to adopt the GS1 standard. And it is not just one standard, it is a set of standards, which in summary can be classified as standards for identification, for capture, for sharing, and for use. And one of the major issues that is going on now is how to start having more standardized product identification that can be assigned from the manufacturer and then can be used all across the supply chain until the end beneficiary. And this is where can be implemented through something like the standardized national product catalog. And once we have the identification, again, this is very critical to start with the identification. Then after having the identification, we can come to the next step, which is capture, which we call it the automatic identification data capture. This is where you can start capturing some of this information through barcoding, either for product identification or for global identification, global location identification. And this will be very important to ensure the interoperability between the various systems. Again, because now we are not talking about one system or one organization, but we are talking about system data that is crossing multiple systems. And once we have this foundation in place and we're able to exchange data, this is where there will be tremendous wide of application and use, from full data visibility, from track and trace and traceability, and so on. Next slide. So in summary, we see, again, there is a global trend for increasing the level of the digitization. We see more and more adoption of standard. We see more and more use of electronic data exchange. We start seeing more implementation in our domain for control tower and data aggregator, like what we can see from the global family planning van. We can see there is more expectation now that the supplier will be sharing electronically advanced shipment notice. And of course, it's becoming very critical to have a proper management and establishment of a standardized based national product catalog. So this is in general term of more what's happening at the global level, which of course have a reflection from what's going at the country level, which Teddy will be highlighting more in the case of Ethiopia and how this has been reflected in reality in Ethiopia. Thank you, and over to you, Teddy.
Thank you, Dr. Rami and Al. So I will be definitely talking about how this global trend has impacted the way things are implemented in Ethiopia, specifically in the digital transformation. Next slide, Al, please. So in the case of Ethiopia, I think first we have to start from what is the major challenge. As it's outlined in the title, it's data visibility. In this data visibility, we would like to make sure the supply chain data, the chain of data transfer, regardless of the physical routing it's taking from manufacturer to all the way to the patient, is not available at any given point. When you want to find where a given product is and which product is, it's very difficult to look at it. So this issue is not from the lack of digitization of the supply chain in the country part, specifically the first slide when Dr. Rami talked about, the different functionality of the supply chain, whether it's the procurement, the inventory management. All of this has been a lot of investment from USAID and other donors in country to support this digitization and digital transformation. But the issue is, once the data is coming from the global donors through some type of digital tool, there is a missing link in between what we call the regulatory information system before it actually physically received at the central medical store. That is from whether it's licensing perspective or whether it is import permits and pre-import permits and pre-shipment information, as well as a consistent data about the product from the registration aspect of it. So in order to do any kind of traceability within the system, this information system has been a major bottleneck and missing link from us. Just to show you, if you go to the next slide, I'll have tried to depict a bit of the what we are talking about when we talk about regulatory information. So the one you see on the right side, the supply chain information system, the ALMIS, that many countries have invested a lot. Many of the donors, including USAID, has been working on. Talks about, how do we manage inventory of the product, the movement of the product from, the medical store at the center, if there are regional hubs, to the hubs, then actually at the facility level, all the way to the patient. What you see on blue color on the left side is that pre-information that is needed before the medical store is received, where we named it as the regulatory information system. So the regulator will provide licensing, it provides import permits, it captures the pre-shipment information, and as well as facilitate the port clearance. So by digitizing and these functions of the regulatory, we were able to connect what is happening globally in the upstream supply chain from the manufacturer, procurement, and supply. When it arrives in country, all of this information will be digitally received, and there will be an easy transfer of that digitally captured data to the supply chain functions. So what we were able to do in this case is by joining this upstream global supply chain to in-country supply chain through the regulatory information system, we were able to have somehow more or less streamlined data flow from manufacturer all the way to the patient level. Once the data is captured digitally, we were able to transfer it in an as. So if you go to the next slide, just for appreciation of the magnitude of what this transformation does. For example, in Ethiopia case, we have over 20,000 unique items that are flowing through the supply chain commodity, whether it is from private entities, government institutions, NGOs, and others. So what we have decided is in 2018, like I alluded previously, to fill up that gap, we decided to bring the regulatory agency into this digital transformation challenge in order to really, our main objective at that time was ensuring patient safety by using global standard and then controlling the flow of products from manufacturer all the way to the patient. But that has an added value to the supply chain system by allowing us capturing data before it arrives in country, the product arrives in country, and then able to move the data between the regulatory to the supply chain in a seamless manner. So we have clear information of all the registered products in country, all the import requests, whether it is from any of the organization, whether it's private, local, government, or NGOs. And then there is a control on the approval process in a digital manner. We also are able to see, because of this digitization, combating of these counterfeit products. So if the product is not getting permissions through the regulatory and properly cleared from the port, we have developed a mobile tool for the patient to empower the patient. By scanning the product, they are able to authenticate whether that product came through the proper regulatory channel in the supply chain. So those are the really added values we were able to see from this digital transformation of the regulatory system. Next slide. So in addition, as a government regulator, the Ethiopian Food and Drug Administration really allow them, by looking at the data digitally, to enforce most of the policies and processes that are being enforced. One of the things the regulatory agency have decided is the use of global standards. As Rami alluded because of what's happening globally, we were able to adapt and make it a regulation within Ethiopia that any product importing starting this year have to have barcoded using the global standard one. So this will allow us to capture the information digitally directly from the manufacturers. We are also able to link the market authorization given to a product to this enforcement of the policy. We also require the unique product identification to be done for pre-import process. So we exactly know what we are importing, whether it is a private entity naming it or a government entity naming it or others. This also have a big impact on the inspection and verification, whether it is pre-inspection at the port or post-surveillance that the regulator is enforcing. Because again, we exactly know where the product is along the supply chain all the way to the last mile because of this implementation of the global standard. I will be able to show you in the overall architecture in the next slide of when we talk about all the processes that we were able to link. It's a little bit of a tiny slide for the clearly look at it. So what I want to take your attention is, first of all, in order to have this full traceability within a country, the key component that we were able to build is to agree on the what of the product. So what you see, the National Product Catalog is the centerpiece. So any product that is being registered in country now follows that global standard with the minimum identified attributes from the manufacturer. So that information would be used across all of the systems, regardless of who is importing the product or who is transferring the product from one point of the supply chain to another. So whether you are a procurer, whether you are a facility or a pharmacy, a community pharmacy, or an individual trying to authenticate, everybody would have access to this National Product Catalog with a unique identification associated with the global standard. So that will allow us to clearly see exactly where the given product is, which product we are talking about, regardless of the different systems that has been used in the country. So given that, whether this NPC gets the data, it's mainly from the registration of products. When a product is registered for distribution in country, the regulatory will have this registration system. And from that registration system, they would be doing product registration. And then as a byproduct, the NPC would be updated accordingly. And then when you look at the traceability database, from manufacturers as well as from importers, when they get pre-shipment information, when they get pre-import authorization, that information is automatically synced into what you see at the center, the traceability database. And this traceability database, it will allow is all of this movement from the regulatory all the way when it gets to the procurer and wholesaler is going to this traceability database. So by using this iVerify mobile app, the individual patients or individual users can scan the product, and this will take them directly to the traceability database. So they would see exactly where the product is. Not only this, the procurer, whether it is at the central warehouse level or at the wholesaler level, the already existing supply chain system are also linked to this NPC, and they will be reporting to the traceability database as they move the product from the central hub to the regional or district hubs, and from regional and district hubs to the Warada level, and then individual facility level. So this will allow us, by putting all the data into the central traceability database, to easily authenticate across the supply chain. Thank you very much. That's all I have the time for today, and happy to answer some questions.
Thank you, Teddy. There was one question. I think I've tried to answer it. If there's any questions, we're happy to take it. Otherwise, I can ask a question from my side. So Rami mentioned one key point during his presentation, talking about expanding functionalities. Okay. Mute. Teddy, you can go on mute. So this question is for Rami. So you discussed on expanding functionalities on the supply chain system beyond inventory management and warehouse management. So if you can please maybe expand a little bit on that and discuss how those roles fit in within the regulatory body and the different functions or roles that EFDA has over.
Thanks a lot. I'll for this great question. And I'm going to highlight what Teddy has mentioned, like what we have used always in the past, that we have a downstream where countries have their own system, which basically start tracking commodity once commodity arrived to the country. And then we have an upstream system. This is where donor and procurer have their system to procure commodity, and they have full visibility about what's being procured, but stopped also once they ship it to the country. And more and more of the direction now for efficient use of operation of the supply chain and for patient safety, you need to have connection between this downstream and the upstream. And really this connection is happening through the need of automating also the regulatory body. This is where the registration will take place. This is where the import will take place. So if we ignore the automation piece in the regulatory body, it would become much more difficult to have this end-to-end data visibility and the connectivity between the downstream and upstream. You are on mute, Ad.
Thank you, Rami, for the response. And next question goes to Teddy. So you mentioned Ethiopia started working on the regulatory system in 2018. And maybe you can expand a little bit on the different priorities the country took and what advice you give to other countries that are doing something similar from the start. Teddy, are you listening? If you're speaking, your mic is.
Hey, can you repeat the question, please? I was disconnected momentarily.
Okay, that's fine. So you mentioned on your presentation that Ethiopia started digitizing the regulatory system in 2018, and maybe you can expand a little bit on the priorities that was taken in working on this target, and also provide some advice to other countries who are embarking in a new endeavor around this area.
Okay, thanks for that. One great question. I think, since when we ventured into prioritizing the regulatory information system, obviously there are many functions of the regulatory that were needed to be digitized. But the approach we took was what is needed in terms of the seamless data movement of the supply chain information from like I said, the upstream supply chain data, then the downstream, which is in country supply chain data. So for that purpose, we started with a simple pre-import permits. In that pre-import permit, we were able to capture what is being requested from the procurer in terms of data and what kind of product they want to buy. And that approval will let us know what to expect at the port. So that's how we prioritized it initially. So we follow the data movement. What are the critical data that we need at the beginning? And then the next type of data we wanted was from the manufacturer. What are they shipping to us? So in that, we needed the pre-shipment information. So in order to capture that, we prioritize those modules within the regulatory in order to capture them. And then what is the regulatory does at the port for clearance? So they ensure that the licensing and the registration, the market authorization of the product is current. So in order to do that, we made sure that all of these databases are linked. So we prioritize the regulatory registration system as well as the market authorization to be linked to this. So by doing all of this in a gradual sequential manner, by looking at the flow of data instead of the overall information system need, we were able to close that gap in a very smooth and transitional manner. So that's my advice, is to follow what is needed priority first. Otherwise, regulatory functions are huge. Like for example, regulators need post-marketing surveillance. That is the end product. So we focus more on the registration licensing part at the beginning. So those kinds of prioritization would be something I can advise other countries to follow up. And then another key things is really when we think of the supply chain movement, in order to ensure regulators have enforcement capability, having data, visibility, digital is important. And in order to do that, I think regulation has to be backed by law. And there is no better partner in this aspect than the regulatory agency, the Ethiopian, for example, in Ethiopian case, the Ethiopian Food and Drug Administration. So by going through them and then really getting the Parliament of Ethiopia to approve for the regulator the use of that global standard, and mandate is given to the regulator to enforce that, we won't be able to really start this process and journey, and then making sure that all the data systems are compliant in utilizing the national product catalog, the global standard, and that visibility and data sharing that will be required for multiple stakeholders. Thank you all.
Thank you, Teddy. Appreciate that. Dr. Ravi, do we have time for one question, quick question, or should we?
Yeah, sure. You can do one last question and then wrap up. Yeah.
Great, thank you. All right, so our last question is for Dr. Rami. We mentioned the National Product Catalog. Sorry, you mentioned the National Product Catalog in your presentation. And we know that MPC is foundational for any supply chain management system. So maybe if you can please expand on a little bit on the role of the Food and Drug Administration as it relates to the MPC. And so let me leave it right there for you. Over.
Thanks, Alan. I also would like to highlight to what Teddy mentioned. One of the biggest challenges now to achieve traceability and applying standards, you need to have some more of a policy and regulation level, which you need this data from manufacturer. And normally manufacturer and supplier will adhere to a policy and regulation, and you need to have it from this perspective. So in order to, and as you mentioned, the whole idea of a national product catalog and to have this unique global identifier, it is, and to ensure its quality, it needs to start from the manufacturer, and the attributes and definition need to be defined by the manufacturer who are owning the product. But then this data need to be shared with the country and need to be shared across all of the supply chain. So practically for this to happen, it will be very important to have a regulation and policy in place that will require this data to be shared from the manufacturer to the country. And an FDA or the regulatory authority in any country are the best place or the most suited to have this kind of regulation policy. So really the national product catalog should be part and should be owned by the regulatory body in the country. And the other point, it's also, it will be serving multiple systems. So it's not just serving, it will be the linkage between the supply chain system, it will be the linkage with the health information system, it will be the linkage with the regulatory system. So it's also not, it will be serving the country in general whenever they want to reference to the global identifier, which is printed and barcoded on the packages. So regulatory body is the more practical and appropriate entity in country to own the national product catalog.
Right. Thank you for that. I appreciate everybody for coming, and we close here. Back to you, Dr. Abba.
Thank you, Al, Rami, and Teddy. I really appreciate this. I think this is a very important topic that you brought to the audience. I'll just make a comment. I don't think we have time to for you to respond, but as you were describing this, clearly the missing link of digitization of regulatory system, as you guys have talked about, the supply chain is already going through digital transformation, so this needs to be connected. But in parallel, there is a lot of discussion and appeal for regional harmonization of regulatory systems. So that's kind of the next level, right? Because if each country tries to do their own unique digital solution, then how do you begin to, that becomes another bottleneck, but perhaps that's another problem to be tackled once we have addressed this one. So it's fascinating, but thank you so much for taking time to putting together this panel. I'll appreciate that, and Teddy and Rami for participating that to bring an important topic. Appreciate that. Thank you.
Thank you.
We'll see you tomorrow then. Yeah.
Thank you.
Thanks.